Next, we are going to have another panel, and it will touch on a topic that, of course, like I just said, is dear to my heart. It is resources for justice-involved youth. As some of our panelists here were speaking, it is very, very important to also provide these resources for our children in our community, and as early as possible. I think Dr. Martinez did touch on that, about early childhood and talking about these subjects with families early on so that they can understand and seek these resources. So I do want to go ahead and get started with introducing our panelists. Are they online or? Oh, they're here, okay. So, we have Casey. Okay. I just want to put your name. Yes. So we have Casey Koenig, who began her career with Travis County Juvenile Court, where she served as a detention officer, a residential treatment officer, and a recreation specialist. Ms. Koenig also worked in the HHSC Office of Guardianship Services before she obtained her current position as a program specialist with HHSC's Children's Mental Health, where she focuses on connecting children in the juvenile justice system with mental health resources. Our next member of our panel is Kisha Ledlow, and she is a Texas System of Care Project Director in the HHSC Office of Mental Health Coordination, where she utilizes her extensive knowledge of systems of care to ensure that children, youth, young adults, and families are engaged in their communities in order to collaboratively create relevant, effective services for themselves and others. Also present here is Veronica Martinez, who started her career in mental health as a certified family partner and a mother with lived experience. She is now the Director of Children and Adult Mental Health Services in HHSC, which allows her to continue to serve the community and embrace her passion of promoting family voice and person-centered, inclusive, and empowered communities. We also have Liz Pearson, who has 10 years of direct care experience working with at-risk youth and families. She is a manager for children's mental health with HHSC. Her passion is working with children and families to connect to appropriate community resources for their mental health needs and collaborating with stakeholders. And our final panelist is Rachel Samsel, who has over 20 years of experience in providing the health and well-being of Texans throughout the development, delivery, and coordination of services, programs, and policies in adult and juvenile justice systems, mental health and substance abuse treatment, public health, and acute care settings. She is currently the Deputy Associate Commissioner for Strategic Initiatives and Policy for the State Hospital System at HHSC, where she provides oversight and direction on major state hospital system initiatives and policy issues to a statewide system of 9 psychiatric hospitals, 1 youth residential treatment center, and 1 primary health care outpatient clinic. Please let us all welcome our panelists.
All right, good morning, everyone. Thank you so much for having me. My name is Kisha Ledlow. I am the Texas System of Care Project Director in the Office of Mental Health Coordination at the Texas Health and Human Services Commission. And this morning, I'm going to start us off a little talking about the system of care approach, what it is, why it's important, as well as the Community Resource Coordination Groups program that you heard a little bit about earlier in the previous panel. So to start off, I wanted to touch on why it's so important for all of our systems to collaborate to help improve the lives of young people with behavioral health challenges and their families. So we know that 50% of all lifetime cases of mental illness begin by the age of 14, and 75% begin by the age of 24. 1 in 6 youth ages 6 to 17 experience a mental health disorder each year. However, only half of those young people receive services, which leads us to another statistic that there's an average delay of 11 years between the onset of symptoms and actual intervention, which is extremely important information to know because we know that youth and young adults at that age are experiencing a lot of life changes, physically, emotionally, developmentally, developing life skills, and a lot of things can happen in an 11-year span for young people. Which leads me to the next staggering statistic, that suicide is the second leading cause of death in youth and young adults ages 10 to 34. So I'm just going to pause for a second and let that sink in. We know that high school students experiencing depression are more than twice as likely to drop out compared to their peers. In addition, youth with mental health challenges have the worst graduation rate of all students with disabilities. And around 70% of youth in the juvenile justice system have a diagnosed mental illness. So there are many historic and current systemic problems that can lead to some of these poor outcomes and a lack of collaboration and coordination of services for young people and their families. So as you can see on the screen, they include a lack of access to home and community-based services and supports, limited interventions that are many times based on a medical model, disproportionality and disparities in accessing appropriate services and supports at the right place and time, rigid financing structures that really don't allow the systems to collaborate and pool their resources to best meet the needs of young people and their families. And then there's fragmentation, which results in silos among those systems. All of these things can lead to poor outcomes for young people with behavioral health challenges and their families. So to address a lot of these systemic issues, the system of care approach was developed, which is an approach to providing effective, coordinated, and community-based services and supports to young people with behavioral health challenges and their families. And it's really built upon these foundational values of being family-driven. So both at a service level and at a systems level, understanding that family members and caregivers of young people with behavioral health challenges are experts in their own lives and the lives of their children, and can really help not only inform, for example, their service plans at an individual level, but also help improve and inform policies at a systems and state level. It's also youth-guided and youth-driven, meaning that youth and young adults are experts in their own lives. They know what has worked, what hasn't worked for them before, and they should have a say both in their own services and treatment planning, but also at a state level informing policies. It's also culturally and linguistically responsive. We know we all have culture, and we need to make sure that in providing services and supports and developing programs that we're meeting the needs of all youth and families in their unique needs. It also has a focus on being community-based, so understanding that young people thrive when they're in their own communities. And so how can we try to provide community-based services and supports when clinically appropriate to help prevent inpatient or residential programming? The purpose of the approach, as you can see here, it's to decrease duplication. So as you all know, young people with behavioral health challenges are many times involved in various systems at the same time. So education, the justice system, child welfare, behavioral health systems. And it's really about bringing those players all to the table to make sure that we're not duplicating services and supports, which increases our efficiency. It's about leveraging resources across these systems and across these partners to pool those resources together to be flexible and best meet the needs of young people. And it's about removing barriers and filling gaps in accessing services and supports. And ultimately, the goal is to improve outcomes for not only young people and their families, but improve outcomes at the systems level as well. So the system of care approach requires both systems reform and frontline practice shifts to address the problems I spoke about earlier. So at a systems level, it's about shifting from fragmented service delivery, so a young person and family receiving similar or same services in various systems. It's about bringing, again, those people to the table and coordinating the service delivery. It's about increasing access to a comprehensive service array. It's also about, instead of being reactive and crisis-oriented, there's a focus on prevention and early intervention, understanding that if we can reach those young people and families early, then they may not be as involved in those other systems later on in life, and they will have improved outcomes. And it's really also about building on, I don't know why that cut off, building on strengths and resiliency. So making sure that instead of focusing on the flaws or the deficits of young people, that we're really building them and their families up. At the service level, it requires a shift from control by professionals to true partnerships with families and youth. Also partnerships with natural and professional services and supports, because we know that young people and families many times have a lot of natural supports in their lives, and we can really help them leverage that to help support them. Again, instead of having several different service plans across each of those systems, it's about working towards one individualized plan developed in collaboration with the young people and their families, and working towards having one care coordinator versus 2 or 3 case managers. Again, it's about being strengths focused. Again, instead of focusing on the deficits or what we would say are flaws of young people, it's really what are their strengths and what are they bringing to the table that we can leverage. And then really it's, again, focused on that cultural and linguistic competence or responsiveness. So there have been decades of research on the system of care approach that shows that this approach, when done effectively, results in the improvements of the lives of children and youth, the lives of families, service delivery systems, and cost and quality of care. For that last bullet point, we know if we're intervening early and improving access to community-based services and supports, there's less of a need to rely on inpatient settings or residential treatment settings. I'm going to go through this really quickly. Here in Texas, we have the Texas System of Care. That is a statewide approach to really improve outcomes for young people and their families. I'll touch on 2 state-level things that we're working towards to really collaborate across systems. So we are required, HHSC is required to have a memorandum of understanding among all of these state agencies you see on the screen. That MOU was signed in 2018 with the purpose of implementing a comprehensive plan to deliver mental health services and supports to children, youth, young adults, and their families using a system of care framework. We also have the Children and Youth Behavioral Health Subcommittee to the Behavioral Health Advisory Committee, which is comprised of all those state agencies that you saw on the previous screen, as well as advocacy organizations, families and young people, and local communities to provide interagency oversight for children's mental health initiatives, including the Texas System of Care, as well as to provide recommendations to the Behavioral Health Advisory Committee on topics related to best practices in children's mental health. So this is just an image to show kind of the system of care approach from the individual level out to the systems level, understanding that through all of these levels, those system of care values should be infused and implemented, and each of these levels should be feeding information to each other to make sure that we're hearing from young people and their families, to make sure we're hearing from providers at a state level, so that when we're developing policies and programs, we're actually developing them to meet the needs of young people. So as you heard earlier, community resource coordination groups, or CRCGs, are county-based interagency groups located in 247 counties, supported again by a memorandum of understanding signed by HHSC, the Department of Family and Protective Services, the Department of State Health Services, the Texas Juvenile Justice Department, the Texas Education Agency, the Texas Department of Housing and Community Affairs, and the Texas Workforce Commission, as well as TACUMI. At an individual level, CRCGs connect people with complex needs to services and supports in their community. They can serve children, youth, adults, as well as families, depending on the needs of the community. And then at a systems level, CRCGs bring together community partners and stakeholders to share resources, to connect programs, and identify local community needs. They also inform local level systems and the state level system of care about gaps and barriers in accessing services and support so we can make informed decisions. This is a list of common CRCG membership. Typically, it's community-based members as well as local affiliates of the mandated state agencies listed on the previous slide who entered into the MOU. And really, each CRCG will determine who needs to be at the table to meet their community's needs. In terms of eligibility, ultimately, if a family or individual needs services and supports that one particular agency can't provide, and multiple people need to come together to help coordinate services, CRCGs may be the right fit. Individuals or families can be referred by a variety of individuals or groups. Ultimately, anyone can refer to a CRCG. So that could be a CRCG member, a local agency or community organization, an individual or family themselves. And on this slide, you can see if you would like to find your local CRCG in your county or community, there is a website where you can search and find the contact information for the local CRCG leaders. And that is my part of the presentation. Thank you so much. If you have any questions about the Texas system of care, you can contact me. My email address is on the slides. And if you'd like to learn more about CRCGs, you can email the CRCG team within the Health and Human Services Commission.
Thank you, Kisha. As mentioned earlier, my name is Veronica Martinez. I'm Director of Children's and Adult Mental Health Services here with HHSC. And I really wanted to bring some of my team members to this presentation because along with our direct service providers, they really are the ones that I just get to talk about the incredible work they're doing. And I have to say, it is really incredible to speak to a live studio audience because it feels like I haven't done that in about 2 years or so. And so I'd like to, this presentation, Kisha spoke on the importance of early intervention. And so we're going to speak a little bit about the local mental health authorities and local behavioral health authorities and the resources that they are for the local communities. Also, we're going to discuss some best practices that we've learned, and we're also going to share some resources. Okay, so what is the role of the local mental health authorities and local behavioral health authorities? So the LMHAs and LBHAs offer crisis services and access to specialized mental health care, including evidence-based practices, promising practices, and other supportive services for children with a serious emotional disturbance. The Children's Mental Health Team, we provide the administrative oversight of our local mental health authorities and local behavioral health authorities. There are 37 LMHAs and 2 LBHAs. Here's a map of our service areas, and as you can see, we cover all 254 Texas counties. I would also like to mention that the local mental health authorities use the Texas Resiliency and Recovery Model, and this model is the service delivery system for our LMHAs and LBHAs. It establishes eligibility for receiving mental health services, determines a recommended level of care, and provides guidance about level of care authorization. And so the way that we do that, here's kind of a visual for that, is that we use the CANS assessment. The CANS assessment means the Child and Adolescent Needs and Strengths Assessment, where we assess for the strengths and also the needs of the child. And I'd like to just mention here one of our levels of care, level of care 0, which is for crisis services. Each LMHA and LBHA has a 24/7 crisis screening and response system where a person can call the crisis hotline and the center will provide a phone screening and determine whether this is an emergent, urgent, or routine crisis. And if necessary, they can deploy an MCOT, which is a mobile crisis outreach team. I'm also going to speak about other areas where we have some intersection with children that are justice involved. Some other programs that we oversee is the Residential Treatment Center Project. This project is in partnership with the Department of Family Protective Services, and its real goal is to keep families together and to prevent relinquishment of rights from parents in order to get residential treatment center care. In fiscal year 2020, the program received 143 unique referrals. In fiscal year 21, we were able to place 54 children and divert 61 children. We had an increase of 32% of children that were able to be placed through the RTC project. I'd also like to mention coordinated specialty care, which is a very unique program that is only available at the local mental health authorities. It is available at 24 of the 39 local mental health authorities, and its purpose is to serve children or to serve individuals ages 15 through 30 that have had their first episode of psychosis within the last 2 years. It's a team approach, and we've really have found some great outcomes. I think it's important to bring this up to the group because we would like to see more referrals from children ages 15 and up. We feel as though it's a really valuable resource. Our team also we monitor the inpatient care wait list. So when a local mental health authority determines that a child requires inpatient services, but there are no other inpatient services available in the local service area, the local mental health authority places the child on the inpatient care wait list. And it's really the gatekeeper to state hospital placement if necessary. So this part of the presentation is really discussing some of the best practices that we have found when working with children that are justice involved. So we find that we have started facilitating monthly meetings with Texas Juvenile Justice Department and Texas Department of Criminal Justice. We find that it's important to develop those relationships not during a crisis, not when everything is really on fire, and do that at a time where we can know who we're calling whenever there's a child in need. We connect with the local mental health authority and local intellectual and developmental disability resources as soon as possible. We also prioritize immediate technical assistance to LMHAs and LBHAs to be responsive and in pace of the juvenile court system. And we coordinate and convene case consultations as requested by state and local agencies. So, along with our local partners, with the local mental health authorities, the LIDAs, the families, the youth themselves, we also ask for support from these other HHSC partners. Not listed on this slide are our internal HHSC partners, which includes State Hospital, the Office of Mental Health Coordination, our crisis team, the Yes Waiver team, our substance use disorder team. We really do a lot of internal collaboration as well. Part of the reason that we wanted to discuss this was because we feel as though these cross-agency consultations have been really valuable, and that they promote the system of care approach that Kisha was just discussing. And the local community is in the driver's seat, and the state agencies provide support, and we also hold each other accountable whenever a state agency says, when a state agency says we need special support and consideration for this child as they transition back into the community. I'd like to discuss just an example of this type of coordination. So we recently had TJJD requested support for a young lady that was transitioning back into the community. This young lady was being monitored for a multitude of diagnoses and behaviors, including a history of drug and alcohol use. She was behind in school, but had expressed interest in participating in a credit recovery program. She was interested in independent living. The CMH convened the local mental health authority in that county. We also convened the TJJD parole officer, the case manager and counselor, and also the family and the youth. The team discussed the child's strengths and goals and local resources that could come to the table. We discussed possible supports for the family and the youth and the family were driving the plan. Upon discharge, she recognized that some barriers she hadn't anticipated. She discovered that her needs and goals had changed, and that returning to the same neighborhood she lived in when she was arrested was a barrier. TJGD requested a follow-up staffing, and the second staffing focused on identifying barriers and adjusting to meet her needs. We provided technical support, we adjusted her plan, And we are happy to report that this young lady has a job and wants to be a trauma counselor as she gets into her career. She is fully connected to support and knows how and who to ask for help. And as somebody mentioned in a previous presentation, we know that this is a marathon and not a sprint. And so the ability to recognize when to ask for help and who and how to ask for help is a really valuable tool for this young lady. This is one example of how support and planning that includes the youth are more successful, and that when we are flexible and there is room to pivot and go in a new direction based on the needs of the individual, we find more success. We find that, whenever we are able to provide those early intervention services, that sometimes for some children, it is important for us to step outside of our processes and bring all of our knowledge and resources together in order to drop the labels and remember that this is a child that deserves to be cherished and to thrive. Okay, so looking forward, we also have some, I'm just going to go through this really quickly. We have some initiatives that we're working on to kind of as another tool in the toolbox related to this type of coordination. One of those is the Behavioral Health Services Online Jail Match Report that we're working on with Texas Department of Juvenile Justice. We're really working on more successful diversion efforts and links to community resources. We are increasing our agency collaboration at the local level, and we're going to be piloting a program where we will have LMHA and LBHA staff with no caseload, that their whole role is going to be in making those connections locally whenever there is a child that could use some more of this additional support. Thank you, and there is the Children's Mental Health Mailbox. If you have any additional questions or need for support, and we've also added some additional resources. I'm going to pass it over to Rachel.
There you go. So I realized the problem with getting a little bit older is that your eyes get to a weird place to where you can't see from there to there, but you can't see from here to the back of the room either. So I've got two pairs of glasses, one to see y'all, one to see the screen. So if I'm just kind of staring into space, we'll see what happens. So I apologize. Yeah, let's see. These will work. Yeah, these will work there. Okay. All right. Thanks. That means I just can't see any of you. So, if y'all are making faces, we'll go with it. So I'm Rachel Samsel. I work with the state hospital system at the Health and Human Services Commission. I'm going to talk to you briefly, and I know I'm the one standing between you and lunch and a break. And so I'm going to highlight some things and actually kind of point out some important resources that are actually in your amazing juvenile bench book resource. So we'll start. So just a quick overview for those of you that aren't aware, the Health and Human Services Commission operates a system of 9 psychiatric hospitals, 1 youth residential treatment facility, and an outpatient primary health care clinic. We actually do have 10 psychiatric hospital locations, but 1 hospital operates under the same name of North Texas State Hospital. So we have 1 campus in Wichita Falls and 1 in Vernon. Specific to our youth services, we do have 4 campuses that provide inpatient psychiatric services to children and youth. Austin State Hospital serves both young children and adolescents. North Texas State Hospital has a specific adolescent forensic program that we'll talk about here in a minute that only serves adolescents 13 to 17 years of age. Their Wichita Falls campus does serve children and adolescents as well. Terrell State Hospital also serves littles and, I'm going to say littles and bigs, children and adolescents. And then our residential treatment facility in WACO primarily serves those that are age 13 to 17 as well. So in a perfect world, the process of, accessing mental health services would kind of be this easy. And, should I drink coffee? Do you have coffee? If not, buy coffee. If you do have coffee, drink coffee, right? It should be that simple. But we know that the general perception of trying to actually access mental health services is more like this.
and people really don't have a good idea. They feel like they're moved from here to here. You know, obviously there are a lot of resources that are available, and so just the vastness of services that are available really kind of makes the whole system a little confusing. But at least from the inpatient side, I'm going to try to simplify this a little bit, and I'm not going to go into too much detail because, again, your bench book is a gem. So just some general information about admission criteria for young people into the state hospitals. And not just the state hospitals, because this also does apply to certain private psychiatric hospitals as well. So your Health and Safety Code, Chapter 572, 573, and 574 covers your voluntary status and your emergency detentions and your court-ordered mental health services. Young people need to be diagnosed with a mental illness, and they also need to be determined to be a danger to themselves or others, or at risk of substantial deterioration. There are the involuntary civil commitments incorporate your emergency detention, your order of protective custody, your temporary mental health commitment, and then something that's a little bit more rare for young people is the extended mental health commitment. In your adult bench book, I think it's page 81, there's a nice table in there that actually kind of goes through the time frame, so I'm not going to go through that level of detail, but I think it's page 81 has a nice table that goes through the emergency detention, OPC, and the mental health commitment, and the time frames and requirements for that. I'll be your Vanna for the bench books today. So we do have young people that do come to us through the criminal justice, through the criminal courts, and so I'm going to equate this to most of us are familiar with incompetent to stand trial. Young people are found unfit to proceed, and so this is due to their mental illness or intellectual disability, and so the same kind of parameters hold true in terms of their similarities to those that are found incompetent to stand trial. If they go back and they're restored to competent, or if they go back and they're found similar to not guilty by reason of insanity, in the youth world, it's found to have lack of responsibility. And so we do provide inpatient psychiatric care for those individuals as well at the majority of our inpatient settings, except for WACO Center for Youth. I'm going to add a little plug for HB 2107 from the regular session, the 87th regular session, which did actually expand the outpatient fitness to proceed restoration opportunities for children with IDD. And so while that opportunity was expanded for those individuals to be able to receive an outpatient competency restoration service, there currently aren't any outpatient competency restoration opportunities for children with either mental illness or IDD. So while that is an option in statute, there really isn't operationally anything that allows for young people to be served on a competency restoration commitment to be able to receive that in an outpatient setting. So our adolescent forensic program at North Texas in Vernon, that campus is a very specialized campus, and we consider that to be our maximum security unit for young people. This serves children, youth age 13 up to the age of 18. They're typically committed under Chapter 55, which is those that are found unfit to proceed or not responsible for conduct. Or they've been determined to be manifestly dangerous. And so most of you are familiar with that process of being found manifestly dangerous when stepping down from an adult maximum security unit typically we talk about them not being found manifestly dangerous. Sorry, let me correct myself on that. When we step them down from maximum security unit to a regional hospital. But in this case, many times we may get a child in our care that needs to step up into a higher level of secure environment. Young people at Vernon also may be admitted under a condition of probation or parole, but then they need to have some type of need for specialized mental health services. They may have a co-occurring psychiatric and substance use disorder, or they've exhausted all other available resources and they've engaged their CRCG, which you heard about earlier, as well. But this program also does exclude young people who are diagnosed with IDD. So there are some that may have mild diagnosis of that, but it is not a primary diagnosis. There needs to be a primary psychiatric diagnosis. So WACO Center for Youth is our psychiatric residential treatment center. It serves a little bit longer term role in the series or in our continuum. They primarily serve young people who need a little bit more time stepping down from a hospital. They've been engaged in services with the local mental health authority, but they've also exhausted other resources out in the community, but do need that longer term treatment program. One thing I do want to mention in terms of admission to the state hospital from Texas Juvenile Justice Department, and this is important because there's a distinction between the type of sentence that the young person is on that kind of guides you into which direction the court needs to take, or which court needs to be engaged, or which process needs to be engaged to get the young person committed. So for a young person on an indeterminate sentence that's already in TJJD, the local mental health authority will actually conduct the crisis assessment and then determine the need for state hospitalization. So typically that results in an emergency detention or preferably an OPC. If a young person is on a determinate sentence, there's a completely different statute that then kind of takes precedent in terms of how a young person comes through under the Human Resources Code, Chapter 244. And that then kind of guides the proceedings through Chapter 55. So although everything kind of ends up in a civil commitment, it's just the pathway and the court that needs to be engaged to be able to get them there. So we've kind of run into a couple of things and had to do some education on the front end with a couple of counties, and so just wanted to bring that up. So big plug. To make this a little bit simpler, some of our team members have taken the opportunity to really develop a map of the Chapter 55 commitment process. And so in your bench book, there is, actually in your juvenile bench book, this is page 81. Page 81 is subchapter B. Page 108 and 109 is subchapter C. And then, 131 and 132 are subchapter D. So we hope that by the development of that resource, that will help folks better understand that Chapter 55 process and how young people move through the proceedings for that type of commitment. And I think, as folks have kind of mentioned, getting young people into the state hospital is a collaborative effort. There are a lot of players involved. We try to really engage everybody to make sure that we're meeting the kids' needs as quickly as possible. And to that end, so there are things from the state hospital perspective that I can do that you can't. There are things that the judiciary can do that I definitely can't. But collaboratively together, we can do things so much better together in working together and having that coordination and communication. So I always thank Mother Teresa for that quote. But anyway, we'll I think maybe have a question or two if we've got time.
I think everyone spoke? Yes? Oh, okay.
Thank you.
So at this time, I'll open it up for a few questions. I know everyone wants to get to lunch and then also our keynote speakers. So does anyone have any questions for our panelists? Oh, go ahead. Okay. I don't either, says my husband. In other words, to get into state hospital is.
Okay, so as Rachel and Veronica mentioned, for the inpatient care waitlist process, the LMHA or LBHA adds them to that list, and that's what you're referring to. So while they're on the waitlist, the children's mental health team and the state hospital team work really collaboratively with the LMHAs and LBHAs to explore any community options. So what we've also found with this coordination and just collaboration, that they can get connected and diverted from state hospital systems. So they may be accepted into a private psychiatric facility, or community resources can meet those needs.
Real examples, because the thing is, I mean, examples of that, where they're located and resource locations. Because sometimes, the reality, and this all sounds really great, but the reality on the ground is that we lack the resources to be responsive. And so, y'all are the same thing. So, I'm the official. Let's ask the question or ask the
No, it's a good question.
So, could you please just talk about the reality of that situation?
We also had a request if the host, if you could repeat that question. I guess our people on online are having a difficult time hearing, and if they don't have the
Oh,
microphone.
okay, so,
Sorry, I thought I had a bigger voice. Okay, so the question is, first of all, where are the kids while they're waiting on the wait list to be admitted? And one practical examples of that. And then also, what you have presented is great. It sounds good, looks good on the slide, but we are out here in the community. Where is the reality? Because we're all suffering from resources. And in the meantime, before we get to utopia, that's the slide, what are we doing in the meantime? Thank you.
thank you. No, absolutely. So, so when a child is placed on the inpatient care wait list, they're in the community. And so typically, the local mental health authority has, if the local mental health authority has been engaged with that child previously, then the local mental health authority comes in and does a crisis assessment to see if further inpatient care is necessary. And so they could be in an emergency room, they could be at home, there could be, they're basically in the community, and that's when they're placed on the inpatient care wait list. We work with state hospital team to see if there's a path into the state hospital, if that is what is clinically necessary. I think that there's, resources are scarce everywhere, and COVID-19, in terms of the capacity that placed for placements across the state, is something that we're working through every day, and we see the strain that is placed on local communities. And so that is the process as it exists, and we can always be engaged if there's an issue or if there's additional support that is needed.
And some of these children are also in detention, correct?
Yes.
And so I guess one last question is, I mean, as you said, the process is great, but again, the wait list is a long wait. The times are, as far as the terms of waiting, can be a lot longer. And if a child is in detention, then other issues start to arise. So I think we have a great, everything in place, but I think everyone working together is probably something more that we have to improve.
Thank you very much for that. Now, as the LVN asked over here, while in the meantime, if they're not in the detention facility, they're home, they're here or there, what are the parents or the caregivers able to rely on if they don't have the training? What are they able to rely on right now, and how can we help to be able to increase that or do something?
So the family is connected to services at the local mental health authority. So the child would go through a uniform assessment, and working with the child and the family, the child would be placed in a level of care, which could include yes waiver, could include intensive case management through LOC4 services, could include medication management, could include, and also can include a certified family partner, which is another resource that I think is extremely valuable whenever your child has reached that level of crisis, and it can really help with navigating the system at that point for the family.